Hello, my name's Michelle Farrar and I'm presenting to you today from Sydney, Australia. And thank you for your very kind invitation to share my experiences of the diagnosis, treatment and management of spinal muscular atrophy at the annual conference for medical genetics and rare diseases and newborn screening in Vietnam. And today I'm going to go over some of the opportunities and challenges in this space from an Australian perspective. So I think it's indisputable that the landscape for spinal muscular atrophy has changed very quickly over the last decade. In 2012, a diagnosis of spinal muscular atrophy inevitably meant for a child with type 1 that the best you were going to see them was the day you diagnosed them, and there was no disease-modifying therapies. So the focus of our care was supportive and often palliative care for these children. And so today, fast forwarding 10 years, there's now 3 approved effective therapies that are safe for the treatment of spinal muscular atrophy. Now, the access to the therapies does vary worldwide, and they differ through their target and also their route and frequency of administration, but they all work by enhancing the production of the deficient survival motor neuron protein. And so there's the oral splicing modifier targeting SMN2 called risdiplam that's given daily. There's an antisense oligonucleotide called nusinersen that's delivered intrathecally with injections with 4 loading doses in the first 2 months and a maintenance dose every 4 months. And finally, there's a gene replacement therapy with a single intravenous infusion of the missing SMN1 gene. So today, I'm going to provide an overview of the changing landscape for treatments, also emphasize the importance of an approach to diagnosis, and then review some of my patient treatment outcomes and what the unmet needs are. So first of all, with the changing outcomes for our patients, there's been a real shift to the classification of SMA. So traditionally, it was based on the age of onset and the maximum motor milestone. So type 1 was onset of symptoms before age 6 months and an inability to sit independently. And type 2 was onset between 6 and 18 months with an ability to sit but not walk. And type 3 had onset in childhood after 18 months with the ability to walk as the maximum motor milestone. But in the setting of newborn screening in some regions and patients now gaining motor skills, this is no longer relevant. It doesn't provide a snapshot of the current status of your patient or what the prognosis is. So the classification has evolved, and it's really now based on the modality of diagnosis, whether they're symptomatic or diagnosed pre-symptomatically by newborn screening, but also on the current functional status, which is sort of related to a therapeutic response. So it's now non-sitter, sitter, and walker. So looking at infantile SMA, and this is a baby that's diagnosed symptomatically, initially being a non-sitter, it's really changed the phenotype of this population. And it's really important to realise that children are going to have ongoing weakness, but they're achieving milestones they never did previously. So this is one baby that I treated who you can see is out in the community riding his bike, which, you know, has some disability assistance with it. And here's another girl who was diagnosed as infantile SMA type 1 who has really gone from being a non-sitter to a sitter to a walker and really evolved. But what we do realise is that it's not just about the delivery of disease-modifying therapy, but proactive care is really important because there's also an evolving phenotype with ongoing weakness in breathing, feeding, and also new orthopaedic features. So really management brings along a care of acute and chronic in terms of respiratory status and also optimising nutrition and the ability to swallow. So an SMA type 1 who is a sitter on treatment, I think it's really important to realise that these children are sitting, but they're sitting with a weak neck and a weak trunk. And really, SMA type 1 never sat previously. And now that they are sitting, this new posture and this new upright is placing new stress on their back, and it's actually placing them at an increased risk of an earlier and more severe scoliosis, but also a kyphosis, which we hadn't seen before. So it's really important that we're recognising this and establishing therapy early, so that while they are sitting, they're not getting fatigued and developing bad postures. So the proactive approach is postural support so that they're getting appropriate seating, orthotics and contraction management. In addition to that, they have ongoing weakness in bulbar function, and bulbar function has two aspects: the ability to swallow, but also the risk of aspiration. And we need to monitor both of these issues. So monitoring time to take eating, the strength of eating, fatigue during eating, and weight gain. And if any of these are an issue, it may be appropriate to have a mixed modality and consider a peg tube, just to have enjoyment of eating, but not that burden of long meal times and fatigue related with those. But it's also about preventing aspiration, which is really important for protecting the airway and the respiratory function. And we certainly know, my own experience is that those that have bulbar dysfunction are more likely to come into hospital with acute illnesses. So optimising this actually reduces the burden of care, the morbidity of hospitalisation, and keeps them out of hospital. So it's really important. So moving on to patients with traditional type 2 or type 3, this is when they are initiating therapy. In stronger patients, we can objectively measure improvements with changes in the Hammersmith motor scale and the upper limb scale. However, there is a spectrum of severity, and in older patients or weaker patients, these scales don't measure effects, but there is definitely subjective and reportable improvement in muscle function, and therefore a benefit of treatment in this population. And I think in terms of what can be achieved in treatment, we can improve neck strength, which helps with sitting upright and participating in the world and being able to look around. Improvements in hand strength and tremor, so more time riding, less fatigue riding, being able to manipulate, do artwork, power, you're mobilising your power wheelchair. Improvements in voice strength, also endurance, chewing, bite force, and also proprioception. But it's only going to improve muscle strength. It's not going to improve the complications of muscle weakness. So disease-modifying therapy is not going to improve contractures that already exist, and it's not going to improve scoliosis as well. So it's really clear that to get the best outcomes from care, it has to be, and treatment, it has to be combined with supportive care and therapy to overcome these. But when we think about the pathophysiology of spinal muscular atrophy, it's really important in terms of understanding the absolute importance of an early diagnosis and early initiation of therapy. And this is because time is motor neurons and it's irreversible. You can't turn around the motor neurons that you've lost. And you can see from the slide, the graph on the left, that children with SMA can have a very early, radical, rapid loss of motor units. And the time course is in the first days to weeks for SMA type 1, in the first weeks to months for type 2, and in the first year for type 3. And you can see on the right, these are some CMAPs that I did in 2 of my patients that were diagnosed and referred to me by newborn screening. And you can see that on day 17, this infant who was at risk of developing SMA type 1 with 2 SMN2 copies had an initial CMAP of 3.9, but over the next 8 days, it was already starting to reduce. By the time that we'd been able to confirm the diagnosis and initiate therapy, it dropped to 2.6. But even more extreme is the patient on the far right, who was referred age day 4, and by the time we confirmed the diagnosis on day 18, so in the second week of life, the CMAP was 3.1, but over the next 2 weeks, while we were arranging therapy, the CMAP had dropped 90% and was 0.3, and symptoms were evident. So really the take-home message from this is that an early diagnosis is important, but this is a medical emergency in a newborn screening scenario, that we don't want to delay diagnosis and treatment of therapy. So access to therapy is equally as important as getting an early diagnosis, and they need to be coupled together. And so I think the imperative for an early diagnosis also comes from the pre-symptomatic clinical trials. And this is the data from the SPRINT study, which looked at the safety and efficacy of onasemnogene abeparvovec. And there were 2 cohorts, and this is the cohort for pre-symptomatic infants aged less than 6 weeks at treatment initiation with 2 copies of SMN2. So they were at most risk of developing SMA type 1. And these are their motor outcomes at the end of the study at age 18 months. And what you can see here is that all patients were sitting independently, and most of them within the normal developmental window for typically developing children, which is shown in the red shading. In addition, 2/3 of them were walking independently by the end of the study, and 1/3 of them were doing so within the shading for the normal milestones that would be expected for typically developing children. So I think primary motor neuron and early diagnosis, especially if you're pre-symptomatic and you're able to access therapy, really gives you the best chance to get the optimal motor outcome for your patient. And so for the second cohort, which was children at risk of SMA type 2 or 3, with 3 copies of SMN2 who accessed onasemnogene abeparvovec through the SPRINT trial before the age of 6 weeks. And this, the conclusion from this study is one of my favourites: from patients who survive to children who thrive. And so what this means is that at the end of the study, at age 18 months, all children were sitting independently, and 13 of the 14 were walking independently, and most of them within the normal developmental window for typically developing children. The one child that wasn't observed to be walking independently, it was because it had to be video confirmed that it wasn't captured on video. So what does this all mean? I think it really does come back to the point that it is really important that we are identifying patients early and initiating therapy. We all know that patients do experience a delay in diagnosis, and that can be due to a lack of experience with rare disease in recognising the early symptoms and signs. But it's also because there can be a long waiting time for specialist visits to confirm the diagnosis. And what we do in regions of Australia that don't have newborn screening, and before we start a newborn screening, is we increase awareness around the symptoms and signs. And we encourage our colleagues to contact us and to write query SMA on the referral. And we would always triage them as urgent and see them as soon as possible. We also know that there can be wait times to confirm the diagnosis and then get approvals to access therapy. So it does require close conversations with the laboratories and the approvers to really help them understand why it's important that they're working quickly and we're working together as a team. But what this all means is that we are changing from supportive care. We have to be proactive, and we have to be proactive across every single domain, from diagnosis to multidisciplinary care to treatment initiation. But how we can do this best is through newborn screening, because this is the best way to get an early diagnosis. And an early diagnosis allows the decision-making and the option to access treatment to really treat the motor neurons and prevent loss or minimise it if possible. We do know that through newborn screening, delays are still possible. It can be delays in getting a confirmed diagnosis or accessing treatment. So what we really need to do is continue to work together across all the different parties that work through this in this sphere to make sure that we're understanding the importance of being quick. Every day counts. So really, I think I presented the clinical trial data from the SPRINT, but what about in the real world? What about the intervention of newborn screening coupled with early treatment for all comers, the full gamut of children that would be identified? So I think it is a new way of thinking about things, and our own experience now that we've screened over 400,000 babies in New South Wales, where I work. It's a large state, and we've identified 30 children with SMA. It's a new paradigm, something we've never seen before, and we're seeing babies often before they get symptoms, but sometimes they do. And it was really, well, what is pre-symptomatic in a newborn, or what is early symptomatic? They're not going to have florid symptoms. So it can be subtle. Babies can have hyperreflexia just before they develop symptoms and get areflexic. They can be hypotonic. We found that it can be related to feeding, or it can just be floppiness around the neck. They can have tongue fasciculations. Look at the breathing pattern. Sometimes it is abnormal. They can have a weak cry or feeding problems. And in fact, 20% of newborns at risk of SMA type 1, that can be their initial presentation, feeding problems. But SMA can also affect the autonomic nerve. So just be suspicious if you're seeing babies with dysregulation of vascular tone, as you can see here with the mammaritis cuta pattern of the rash on this baby, just irregular skin response to temperature. We also know that newborns can have congenital heart disease, VSDs, or abnormalities of the cardiac outflow tract. So when you're seeing a newborn at risk of SMA, make sure you're assessing cardiac function. And I have also seen babies that present with hypoglycemia. If it's onset in utero, they can also have contractions, particularly around the hips and knees, so examine that as well. So what about what we've learned through newborn screening? So as I said, it was 400,000 newborns, and we identified 32 newborns that screened positive. We confirmed it in 31. One we called positive, but we actually thought it was going to be a false positive because the signal was different, but we really
A severe phenotype can be indicated by 2 copies, and we found that in 51% of newborns with SMA, and 28% of our cohort actually showed signs and symptoms of SMA within the first 4 weeks of life, which we thought was absolutely shocking and we weren't prepared for. But it really is a very important point that other jurisdictions have found as well in terms of the necessity to move quickly. So we did see differences with copy numbers, and you can see on the far left that the 2 copy cohort did have lower compound muscle action potentials, which is a neurophysiological assessment regarding stimulating the nerve and measuring the response. So it was lower. And again, these 3 cases I've shown before, but do show how quickly those with 2 copies can have disease onset and loss of the motor unit pool. So knowing that the cohort can be symptomatic, it doesn't replicate a clinical trial population exactly, but what does newborn screening achieve for all comers, given that some of them are symptomatic? So what we did is we looked at our cohort that we identified in the first 2 years of newborn screening, and we compared them to the cohort that we identified with SMA and diagnosed in the 2 years before we started newborn screening. Now, that cohort could have delayed diagnosis. They could present up to the age of 16 if they had SMA type 3. And we compared their outcomes after 2 years of treatment. And what we saw was that the survival was fairly similar, and however, the motor outcomes were very, very different. You can see that with newborn screening, even though 28% were symptomatic very early, 12 out of the 14 at the age of 2 years of treatment were able to walk independently or with assistance. Now, compare that without newborn screening, and we found that it was only 1 out of the 14 that was able to walk independently or with assistance. That's a huge difference. Now, you can see that a lot of them are sitting, but that's their best motor milestone if you're diagnosed with symptoms and you're accessing treatment. So here's some case studies of some of our graduates. This first boy, was the boy that we showed that actually showed up on day 8 already symptomatic, with stridor, a weak cry, and difficulties breathing. And he started treatment immediately. And you can see that after 2 years of treatment, he's definitely benefited. He can stand and he can take steps with support, but he does have ongoing weakness, but quite a marked response to treatment, and definitely a benefit. But his care requirements are really requiring a lot of physiotherapy, stretching, orthoses, ongoing monitoring of feeding and breathing support. This little baby evolved to be child-evolved symptoms whilst we were diagnosing and initiating his disease-modifying therapy. And you can see that after 2 years, he's just got his new AFO, so he's a bit wobbly. But after 2 years, he's walking independently, but you can see that he has some hip weakness that's evident. So he's going to require ongoing management, and he really does have quite a new phenotype for SMA. So we're going to be watching his joints, his contractions, his feeding and nutrition very carefully. And finally, this little girl with 2 copies of 2SMN2, also at risk of SMA type 1, and here she is, 11 months old, taking her first steps. So actually she's still doing very well, and we continue to follow her development and her breathing and nutrition, but she's really making gains that are online with a typically developing kid. So you can see that the outcomes can be very heterogeneous, but clearly the benefit of newborn screening. So here is another way of showing this. So we looked at our motor outcomes for the 2 cohorts compared to the age of diagnosis. So those that were diagnosed following clinical suspicion and emergence of symptoms without newborn screening are shown in the yellow. And there's a negative correlation. So the later you're diagnosed, the less your motor outcome changes. And we really do know that already. But when we look at newborn screening in all comers, what it shows is we've actually changed the slope of the correlation. And you can see that with newborn screening, the changes are much greater, but an earlier diagnosis really rewrites the history in terms of the prospects for motor outcomes. Those who actually got an earlier diagnosis through newborn screening were those where an initiated treatment were those that were symptomatic. So that's why the slope of the curve has also changed. So what about pre-symptomatic patients? Those who don't have symptoms and start treatment, what are we going to do with their management going forward? And I think SMN2 copy number is very important. And what we do know for those infants with 2 copies who are most likely to develop SMA type 1 without treatment, the severe form of SMA, is that we have to be more guarded. Most of them do well, but they may get symptoms, and we need to be managing them and observing them for that. We know that 20% of them can have some swallowing or breathing problems. We can't forget about that. And as we follow them with growth, there can be some delay in motor milestones, but overall they generally achieve walking. Now, is it that the treatment stops working, or is it that as they get older, the symptoms emerge because the demands on the body are greater? I think this is a problem that we still have to work through. But it's really important from a therapy perspective that we are managing gait, complications of weakness, optimising function, and really doing the physio and looking out for fatigue in this population. In comparison, those with 3 copies, we'd expect them to do very well. The expectations treating pre-symptomatically is that they're going to get normal motor function. It's going to parallel typically developing children, and they should be able to run, and they really shouldn't be getting a lot of the comorbidities that we recognise with SMA, such as scoliosis. So the take-home messages are that SMA is a serious neurological disease, but now it's treatable, and there's 3 different treatments. But to get the best outcomes, we need early diagnosis coupled with early initiation of disease-modifying therapy. And we need to be very proactive and advocating for this to happen to maximise clinical outcomes for our patients. This is best achieved through newborn screening. It really minimises the loss of motor neurons. But really going forward, following diagnosis and treatment, the story's not over. Our patients are going to require ongoing multidisciplinary care and follow-up. Thank you.